Hello friends, today we will discuss how to interpret blood cultures. In the first part of the lecture, we will discuss about the basics of blood culture and what are the common encountered problems. And in the later part of the lecture, we will discuss about the antimicrobial susceptibility testing, and in the last part, we will discuss about some advanced information. I hope you will find this video useful. So let's start. So first we have to understand that whenever there is bacteremia or fungemia, there is a systemic inflammatory response which leads to severe sepsis or septic shock. Blood cultures are gold standard, and the incubating blood in a medium for bacterial growth will eventually give us isolation of microorganism from the blood culture. What is the ideal timing of blood culture? So we know when there is periodical bacteremia and fungemia and periodical fever, the sample should be drawn at the onset of fever. If there is continuous bacteremia or fungemia and continuous fever, then time is not critical. And those patients who are already who have been started on antibiotics, the culture should be sent before the next dose. How much amount of blood should we draw? So for adult blood collection, 8 to 10 ml of blood is required in each bottle. When we send one set of blood culture, it contains one aerobic and one anaerobic bottle. And generally we send two sets of blood cultures. So total 2 aerobic and 2 anaerobic bottles amounting to 40 milliliters of blood. And it should be collected from two different venipuncture sites. If we are suspecting infective endocarditis, then we should send at least 3 sets of blood cultures drawn at least 1 hour apart from different 3 sites, because there is low bacterial count in the blood in such patients, and sending more blood increases the positive yield of the blood culture. The blood culture bottle contains broth, and how much amount of blood to add to the broth, that ratio of blood to broth is very important. The bottle has a black mark to indicate how much blood to send. If we are suspecting catheter related bloodstream infection, then we have to do simultaneous sampling from the catheter as well as peripheral vein. The time to positivity of the catheter sample should be at least 2 hours shorter than the peripheral sample. This is all automated in the current practice. And the cultured microbe and its antimicrobial susceptibility should be same. Then we can say that this infection is catheter associated infection. The time to positivity, sooner the time to positivity also indicates higher load of bacteria, and it gives a prognostic information as well. Now some of you may ask, are anaerobic or fungal bottles necessary? So in patients who have a risk of developing anaerobic or fungal infections, and these include neutropenic patients, post-surgical complicated patients, advanced diabetic patients, and complicated wound infections, these patients can grow anaerobic infections or fungal infections as well, and it is a good practice to send anaerobic and fungal bottles along with the aerobic bottles. If you don't have fungal bottles, even aerobic bottles can flash for fungal infection, and you can grow them further. Now, if you have drawn sample and inoculated into the bottle, you should send these bottles to the lab immediately. In case this is not possible, then these bottles should be maintained at a room temperature, and not they should not be refrigerated. Now, if you look at this picture, you can see the colors are different. So the one with the positive sign, that bottle has flashed something, and the one with a negative sign has not flashed anything. So when we say blood culture has flashed something, That means some growth is detected in the blood culture, and this flash is given by the automated machine itself, and that's why the color changes. This color change is because of the microbial growth leading to carbon dioxide production and leading to pH indicator color change, and this positive change is automated. So what happens once the blood culture bottle flashes positive? So the next, within few minutes, we do gram stain of the sample. Then within few hours, we do further test and identify the organisms. So either we can get a presumptive diagnosis or definitive diagnosis based on the different tests that we do. And once we have some organism in mind, and then we further do susceptibility reporting, and within few hours after that we get the antimicrobial susceptibility report, which is what we get when we send the blood culture. Now, why would a culture be negative? So if you are strongly suspecting infection and the culture has come negative, this happens in around 50 to 60% cases, and some clinical factors also contribute. These include inadequate sample or too much sample, amount of blood, the number of bottles used, so less number of bottles may yield negative. Now, why is the culture result negative despite a positive signal? So this can happen if the blood is too much blood is filled in the bottle, leading to false CO2 alarm and false positive signal. It could happen in ventilated patients who have elevated PCO2 or patients with very high WBC count. For example, hematology patients, they can also have high CO2 and it is falsely detected or falsely flashed as positive, but subsequently you don't get any growth. What if only aerobics bottle flash and anaerobic bottle does not flash? You have to strongly suspect strict aerobes, and common aerobes include Pseudomonas, Burkholderia and Candida species. Now if blood culture bottle flashes, you get something in the gram stain, but subsequently there is no growth on plating. These could be difficult to grow organisms. These are Brucella and Hesek. I will shortly discuss a case of prosthetic valve endocarditis, and this was a challenging case for us as well. So, this was a patient who came to us, 66-year-old lady with prosthetic valve implantation in the past and a background of rheumatic heart disease. And she came with fever, respiratory symptoms, and she had a history of recent dental work. The blood culture grew gram-negative bacilli, but we could not detect anything on the chocolate agar even after 48 hours. So we were in a dilemma, but we did subsequent MALDI-TOF MS testing and we identified Haemophilus parainfluenzae in this patient. For the first 2-3 days, the patient was on meropenem and she was having fever spikes. Her WBC were elevated, and we were very, not very sure whether she is showing some clinical improvement. But after detection of this organism, we added levofloxacin to the regime, and within 24 hours, we saw very good response, and WBC and fever, both things improved. What this tells us is we have to be aware about the Hesek group infection possibilities. That is one, especially in the background of prosthetic valve disease. We should use advanced diagnostic, including chocolate agar, prolonged incubation, MALDI-TOF MS, or multiplex PCR test to come to the diagnosis. And empirical therapy should be considered if we are suspecting Hesek organisms. Now there are some strict anaerobes like Bacteroides fragilis, which can be found in the human gut, and they are commonly seen in patients who have advanced diabetes, complicated abdominal surgeries, or immunosuppressed patients. Now, after the basics, we will discuss some points about antimicrobial susceptibility testing. So first, to define antimicrobial susceptibility, determines the effectiveness of antibiotics against specific bacterial isolates. The purpose is to guide clinicians in selecting the most appropriate antibiotic. and this is crucial for combating resistance and ensuring optimal patient care. The techniques include disk diffusion, broth dilution, and automated systems. I will give you an overview of the testing process. So first, single card testing of patient isolates is done. Then continuous growth monitoring by Vitek2 system is done. And finally, the growth analysis comparing antibiotic wells to a control is done. This ensures accurate and efficient result for patient treatment. So as you can see, first the AST card, which contains multiple wells with increasing concentration of antibiotics. From the bacterial culture which has flashed positive, a standardized suspension of the isolate is prepared, and then the AST card and bacterial suspension are loaded into the automated system for incubation and analysis. This method gives us the MIC value. We will discuss about MIC in subsequent slides. Now we are using Vitek2 system in our hospital, and I think most of the hospitals are using this. It is a fully automated microbiological system. It provides rapid and accurate identification and susceptibility testing for a wide range of microorganisms. This system uses a unique technology called colorimetric detection to measure the growth of bacteria and fungi in the presence of different antibiotics. Now, how do we determine MIC? It is also an automated process which depends on multiple factors. So it involves comparing the patient isolate growth to known MICs using a standard curve, relating reference MICs to antibiotic well activities, and finally analyzing the patient isolate against this curve to obtain the final MIC value. I am not going into detail on this because I don't think this is necessary for us because it is automated. So let's move forward. Now, an important thing clinically is to know what is MIC and what is breakpoint. So MIC is the lowest antibiotic concentration that prevents bacterial growth, and breakpoint is a concentration that determines susceptibility or resistance to the antibiotics. Breakpoint also considers expected tissue concentrations after standard antibiotic doses. What factors determine the breakpoint? So inherent susceptibility, of course, to the antibiotic, the pharmacokinetic and pharmacodynamic principles, and clinical outcome data and the real world evidence. Now let's see, there are three breakpoints that we normally see in our culture reports. Susceptible means the isolate is inhibited in vivo with standard doses of, and there is high likelihood of therapeutic success with that particular antibiotic. Resistance means the isolate is not inhibited in vivo with standard doses and the treatment with that antibiotic is unlikely to be effective. And intermediate means there is uncertain therapeutic effect. The antibiotic may work with higher doses, but the clinical trials are not very confirmatory. Now, how do we choose the best antibiotic? So we have to look for lower MIC, of course. Lower the MIC, lower concentration is needed to kill microorganisms. We also need to know the susceptibility breakpoints, which will subsequently give us information about breakpoint to MIC ratio. And higher the ratio, there is more likelihood of therapeutic success. This is an example. Now, if you see, the organism is sensitive to almost everything in this table except for ciprofloxacin, which is intermediate. And if we look at the MICs, it is 0.25 for ceftriaxone and 0.25 for meropenem. So we can say that ceftriaxone and meropenem are likely to work because the MIC is lowest. However, we don't know the breakpoints. So we cannot take a decision just based on this information to say whether one antibiotic is superior than the other. For this, we need to know BMQ to breakpoint, BMQ breakpoint to MIC quotient. So this is a ratio of breakpoint to MIC level. This is also called MIC therapeutic index. Higher the number indicates better the choice of antibiotics. And this helps compare antibiotics effectiveness based on the MIC and breakpoint values. So this is a useful information. This information is generally available. These cards, breakpoint cards, are available with all the microbiology laboratories where Vitek systems are being used, and you should ask for these breakpoint numbers to get more information when you are taking decision to start any antibiotics. Now if you look at this culture report, you can see that this organism is susceptible to meropenem, imipenem, ertapenem, tigecycline, and intermediate to colistin. So there are 4 choices that we have. If we look at the MIC for meropenem is less than 0.25, imipenem is 0.5, ertapenem is 0.25, and tigecycline is less than 0.5. But if we look at the susceptibility breakpoint as well, they are different. So less than 1, less than 1, less than 0.5, and less than 2. And if we take out the breakpoint to MIC ratio, then the ratio comes to be more than 4 for meropenem as well as more than 4 for tigecycline. So for this patient, amongst these 4 antibiotics, meropenem and tigecycline are likely to work superiorly compared to imipenem and ertapenem. If we are suspecting a bloodstream infection, then meropenem would work better because it's a bloodstream infection and meropenem is bactericidal. I hope so far you have understood what we have discussed. Now we will discuss a little bit about staph aureus in blood culture. So when blood culture grows staph aureus, we take it very seriously. We do a thorough examination and take detailed history to identify focus and go for rapid source control. We look for community acquired pneumonia, intracardiac foreign material including prosthetic valves, electric devices, predisposing risk factors including heart transplant, endocarditis, patients on dialysis, patients may have septic emboli, spondylodiscitis, osteomyelitis, IV drug abusers. And if any of these suspicions history is positive, then we go for a transesophageal echo to rule out bacterial endocarditis, and we do a follow-up blood culture after 48 hours for all staph aureus patients. This is not MRSA, this is just all staph aureus patients, including MRSA as well as MSSA. Now, if after 48 hours also the culture is positive, then we have to further do testings and repeat a TE, do a PET CT scan, and further follow up with the blood cultures to identify source and remove source. All this exercise is done to rapidly treat these patients because these infections are associated with high mortality. If the subsequent blood culture is negative, then we continue the treatment depending on further clinical course. Now, if we look at this culture sensitivity, this culture has been reported as MRSA and there is no mention of methicillin in the culture. So here we have to note that oxacillin is taken as a marker for methicillin resistance. This isolate is resistant to oxacillin, so they have reported it as methicillin resistant. What are the risk factors for MRSA in HIV patients? So as we all know, these patients have medical risk factors, low immunity, and behavioral risk factors, which include history of imprisonment, alcohol abuse, heterosexual behavior, homelessness, and illicit drug use. Any previous hospital stays, any previous procedures, these all risks contribute to possibility of having MRSA infection in HIV patients, and this is associated with serious consequences. Now, if a patient is positive for influenza, they are also likely to get MRSA infection because the immunity is weakened by influenza and the individual become more susceptible to secondary infections. The secondary pneumonia by bacteria like MRSA can significantly worsen the outcome in influenza patients. Now that's about the staph aureus and MRSA. Now if you look here, this is a staph epidermidis. So this is a coagulase-negative staph. And here also you can see oxacillin is resistant. So this means this is a methicillin resistance coagulase-negative staph. This is MR-cons. Now a little bit about inducible clindamycin resistance or MLSB resistance. So the full form is macrolide lincosamide streptogrammin type B, MLSB. This is associated with 4 genes, and these genes produce methylase, which modifies the ribosomal target site and it prevents the antibiotic binding, leading to constitutive and inducible resistance. So, when erythromycin, which is a strong inducer of methylase enzyme, is added, such isolate is it can induce production of methylase and it can induce resistance. So, whenever we are giving sensitivity for clindamycin, we also do sensitivity with erythromycin, and here, like in this picture, you can see because of the presence of erythromycin, there is no inhibition in that area and a D-like shape is seen. So this means that the clindamycin resistance is induced by erythromycin, and this patient is likely to have therapeutic failure if this patient is given clindamycin. So in our test also, you can see at the bottom inducible clindamycin resistance is positive. So this is the meaning of inducible clindamycin resistance, and it is a good practice from the laboratory side to give this information to the user. Now, blood culture with coagulase-negative staph include staph hominis, staph epidermidis, staph saprophyticus, and staph hemolyticus. Generally, these are skin contaminants, but if two or more cultures grow the same organisms and if the patient is immunosuppressed, then we have to consider them as pathogenic. Now, something about the gram-negative bacilli in the blood culture. Presence of GNBs is always positive and always pathogenic in blood culture, and we have to gather information about the risk factors, including recent hospitalizations, lines, antibiotics, immune status of the patient, and underlying health conditions. We can do once if blood culture flashes positive and shows GNB in the gram stain, we can do direct broth plating or lawn culture to get faster yield and faster results. This is an example of Klebsiella pneumoniae in the blood culture, and you can see it is resistant to all the antibiotics tested and also intermediate to polymyxin B. So this is a real dilemma and real challenge in our practice, that we are getting more and more multi-drug resistant gram-negative infections. This is a Pseudomonas aeruginosa isolate, and it is showing intermediate sensitivity to colistin, levoflox, and amikacin, and resistant to carbapenems and cephalosporins. There are some surrogate markers of drug resistance, like if the patient bacteria is producing ESBL, extended spectrum beta lactamase, it inactivates penicillins and cephalosporins. So if you get ceftriaxone resistance with beta lactamase combination sensitivity, it is likely to be ESBL. If resistance to cefoxitin is noted, it is a surrogate marker of detection of MPC beta lactamase. And if resistance to meropenem or carbapenem is noted, it is a surrogate marker of carbapenemase producing organism, and it indicates multi-drug resistance. If you get carbapenemase enzyme positive in your cultures and you are strongly suspecting and the culture is showing resistance to the standard antibiotics, then you have to investigate further and you have to detect which carbapenemase enzymes are present. So there is expert CARBA-R test which detects KPC, NDM, VIM, OXA48 and IMP1 carbapenemases. There is a lateral flow assay as well for carbapenemase genes, and if the organism is growing NDM, VIM or IMP, these patients are generally resistant to ceftazidime avibactam. If the patient is growing KPC or OXA48, these carbapenemases are sensitive to ceftazidime avibactam. So whether ceftazidime avibactam will work or not will be determined by the presence of genes. Now, if the patient has NDM, which is the predominant observation in our practice in India, then in some studies they have shown that synergistic effect of ceftazidime avibactam and aztreonam. So the zone of inhibition you can see here is bigger when the ceftazidime avibactam and aztreonam are used as a combination. So if you do, this is called synergy test. So if your synergy test shows inhibition, then you can use ceftazidime avibactam plus aztreonam for NDM, VIM and IMP genes. If you have NDM, VIM and IMP and synergy test does not show good response, then using this combination is not likely to be helpful, and polymyxins should be considered. Blood culture comes positive, we have to also think simultaneously about other sites of infection. So we have to think about presence of pneumonia, UTI or meningitis along with the positive blood culture and treat accordingly. Now some practical considerations for colistins. So colistin susceptibility testing is recommended and it has evolved over time. The breakpoints are available for Pseudomonas, Enterobacteriales, Acinetobacter baumannii complex in both CLSI and EUCAST. Colistin and polymyxin B are equivalent and they can be interpreted with each other. And the recommended method is broth microdilution technique. As we can see, EUCAST gives sensitive and resistance to colistin in colistin breakpoints, and CLSI gives only intermediate and resistant. CLSI does not give sensitive breakpoint. And in our practice, we have been using following CLSI. So in our reports, colistin is reported as intermediate or resistance. It is not reported as sensitive. This is done to discourage or reduce the use of colistin without any support. So there are recommendations to use colistin. Colistin and poly B should be given with a loading dose, and maximum renally adjustable doses should be given. Use of polymyxin should be minimized, and alternative agents, if any present, should be strongly considered. Combination therapy for systemic infection should be considered over monotherapy. And for pneumonia, use inhaled as well as systemic therapy with polymyxins or colistin. Now if you look here, this patient has grown Serratia marcescens and it is resistant to colistin but fairly susceptible to many other antibiotics. So what does this mean? So we need to understand that Serratia marcescens, Morganella morgani, Burkholderia species and Proteus mirabilis are intrinsically resistant to colistin, and these infections can grow in patients who have been receiving colistin or polymyxin for a longer time. Now, what are the methods to decrease the time for pathogen identification? Because as we know, blood culture may take 2 to 3 days to get the result, and then we may be able to take some action. So use the flashing bottle culture for rapid diagnostic, which can be done by antigen detection for pathogens like Streptococcus pneumoniae, Neisseria or Streptococcus agalacti. There are semi-automated or automated systems which can identify gram-negative sepsis pathogens in 92 to 99% of cases, and gram-positives are in 43 to 75% of cases. This can give you information in 4 to 16 hours, which is still a lesser of time. And there are advanced techniques for rapid pathogen identification, including MALDI-TOF MS and multiplex PCR. So MALDI-TOF MS is a mass spectrometry technique that quickly identifies microbial organisms from small samples, and it can detect colonies after short incubation, allowing faster reporting. Multiplex PCR is also from positive culture bottle. You can send them for multiplex PCR and they can identify bacterial or fungal DNA and also certain resistance gene, which we saw in CARBAR or the lateral flow. These genes are also detected in multiplex PCR. Now, when should we do follow-up blood cultures? So in certain cases, just a single positive culture is not sufficient, and we have to do follow-up cultures. These conditions include infective endocarditis, where the blood sterility may not be achieved even with treatment, and we do follow-up cultures to see whether disease is eliminated or whether any resistance has developed to the previously sensitive antibiotics. For staph aureus bacteremia, we have discussed earlier also to detect complicated sepsis and guide the therapy. For Candida bloodstream infection, we do daily follow-up blood cultures until the culture is negative, and once the culture is negative for 14 days, we stop the treatment. And Pseudomonas, it is seen that there is acquired resistance while the treatment is ongoing, and follow-up culture is needed if the clinical response is not adequate. So infective endocarditis, staph aureus bacteremia, and Candida bloodstream infection definitely merit follow-up cultures. And in Pseudomonas, if your response to treatment is changing or not improving, you may consider follow-up blood infections. Now enough about bacteria and some discussion about Candida. So if you see this report, this is Candida auris, and if you see, it is resistant to amphotericin B and fluconazole and susceptible to caspo and micafungin. This is a new, relatively new infection which has been detected in patients with multi-drug resistant infections and who have prolonged antibiotic treatment and whose immunity is also not great. So this Candida auris is associated with high mortality. And as we discussed, antifungal therapy for any Candida bloodstream infection has to be given for 14 days after a negative blood culture. And species identification is important because if it is Candida auris, then it can lead to serious problems. Daily blood culture is recommended for Candida bloodstream infection till the blood culture becomes negative. Now in the end, so is antimicrobial stewardship cost effective? Whatever we discussed so far was antimicrobial stewardship, because we discussed about the right antibiotic for right patient in right dose at the right time. That is the theme of antimicrobial stewardship. So we have to think about cost effective. If you think about the cost of cultures, if you think about the cost of biomarkers or cost of daily antimicrobial therapy or cost of daily ICU stay, you get the answer yourself. Cost of blood cultures and biomarkers are significant, but compared to that, cost of daily antimicrobial and antifungal medicines and daily ICU stay are much more higher. Also, there are intangible costs. Can you measure the cost of morbidity and mental agony for the patient? And can you measure the cost of life for individual patient? So I hope with this discussion I have enlightened some bulbs in your head and you may have get some good idea about the blood culture interpretation. If you like this video, please hit like, share with your friends and colleagues and subscribe to my channel. Thank you so much for watching this video.